Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the abscess in the anorectal region. The abscess in the anorectal region is caused by the E. coli in a majority of cases, and the rest by Staphylococcus aureus bacteroids, Streptococcus or B. proteus. In some cases, it is mixed infection. The infection commences as an infection of anal gland. Other causes are penetration of rectal wall, blood-borne infection or an extension of cutaneous boil. Many are resulted in a fistula in ano. As antibiotics can't reach the abscess, antibiotic therapy can't be relied. It is to be differentiated from pilonidal sinus, Bartholin's gland and Copper's gland. Types of anorectal abscess. Depending upon the site of the abscess, divided into 4 types: perianal, ischiorectal, submucous and pelvirectal. Perianal abscess. This occurs as a result of suppuration in an anal gland. Spreads superficially to lie in the region of subcutaneous portion of the external sphincter. It may also occur as a result of a thrombosed external pipe. If the hematoma is not evacuated, it may become infected and a parietal abscess results. It is common in any age. The constitutional symptoms and the pain are less pronounced than ischiorectal abscess. Early diagnosis is possible by inspecting the anal margin when an acutely tender, rounded cystic lump about the size of a cherry is seen and felt at the anal wedge below the dentate line. Treatment. Immediate evacuation is done. Operation or a cruciate incision is made over the abscess and the incising the skin edges through drainage is achieved. This completely removes the roof of the abscess. Healing occurs in few days. Ischiorectal abscess. Ischiorectal abscess is due to the extension laterally through the external sphincter of a low intermuscular anal abscess. Sometimes the infection is either lymphatic or blood-borne. The fat which fills the ischiorectal fossa is vulnerable because it is poorly vascularized, hence soon whole space is involved. The ischiorectal fossa communicates with that of the opposite side through the post-sphincteric space. If an ischiorectal abscess not evacuated early, involvement of the contralateral fossa is common. Symptoms. An ischiorectal abscess gives rise to a tender, brawny induration palpable on the corresponding side of the anal canal and the floor of the fossa. Constitutional symptoms are severe. The temperature rises to 1 or 2 degrees Fahrenheit. Men are more affected than female. Treatment. Operation is performed as early as possible, remembering that the antibiotic therapy usually masks the general signs. Operation. Stage 1. A flesh-shaped incision is made into the abscess. An adequate portion of the skin that includes the most, if not all, of the roof of the abscess is excised. The cavity is explode, and if septa exists should be broken down gently with a finger, and the necrotic tissue lining the walls of the abscess is removed by the finger wrapped in gauze. Stage 2. As soon as the acute infection has subsided, the wound should be re-examined under general anesthesia. A careful search is made for a fistulous opening communicating with the anal canal. If such opening is found, the treatment should be continued as for the fistula. If no fistula is found, the cavity is lightly packed with gauze wrung out in any weak antiseptic favored by the operator. A T bandage is applied. When the cavity is covered with the granulation tissue, skin grafting expedites final epithelialization. Submucous abscess. It occurs above the dentate line. When occurs after the injection for hemorrhoids, it always resolves. Treatment. It can be opened with a sinus forceps when adequately displayed by a proctoscope. Pelvirectal abscess. Pelvirectal abscess is present in between the upper surface of the levator ani and the pelvic peritoneum. It is equal to the pelvic abscess and is usually secondary to the appendicitis, salpingitis, diverticulitis, or parametritis. It may be due to the over-enthusiastic attempts to drain an istiorectal abscess or to display the site of a fistula resulting from when a probe is pushed through the levator ani from below. Fissure abscess. This is the name given to the subcutaneous abscess lying in immediate association with an anal fissure. Drainage is achieved at the same time as the fissure is treated by sphincterotomy. That's all about the anorectal abscess and the types, and in the next video I will discuss about some other disease. Thank you.